Hello, I'm a member of the Neurobiology of Pain Laboratory of Dr. Kathleen Sluka at the University of Iowa. Fibromyalgia is difficult to have and to treat. Clinical practice guidelines suggest exercise is a first-line intervention for patients with fibromyalgia. Surprise, it's difficult to get anyone to exercise, but for those with fibromyalgia, movement-evoked pain is a significant barrier to exercise or activity participation. We have previously shown that 1 month of TENS reduces both movement-evoked pain and fatigue in women with fibromyalgia. We wanted to look further at our data to determine if there were predictors for success with TENS. Here's the data from our FAST trial. The blue lines show the effectiveness of TENS in a single treatment as well as after 30 days of home use. We saw reductions in movement-evoked pain and fatigue. In the FAST trial, we identified responders to the TENS interventions. Responders were characterized as participants who experienced at least a 30% reduction in pain and or a 20% reduction in fatigue. Lastly, you can see that the number needed to treat for medications used to treat fibromyalgia ranges between 6 and 19. Here, a lower number is desired. NNH is a member of how many people you need to treat for one person to experience an adverse event. Here, a higher number is desired. NNH for medication range from 4 to 29. We collected adverse events in the FAST trial and wanted to compare the effectiveness of TENS and safety with other approved pharmacological treatments for fibromyalgia. So our primary aim was to identify factors that predict the response of TENS, and our secondary aim was to look at NNT and NNH. The current study is a secondary analysis of the FAST study where the randomized phase was 1 month of TENS use, active, placebo, or no TENS at home. When participants returned at visit 3, the no TENS and placebo TENS groups were then instructed in active TENS use, and they completed 1 month of TENS use at home also. 155 of these 198 participants came back for visit 4. In this diagram, B represents the training data set used to determine the predictors using the active TENS group with an intention to treat analysis. The validation set used the placebo TENS and no TENS group who completed the visit 4. Remember, these two groups received active TENS for 1 month also. Here's a list of the outcome measures we collected. The measurements represented in blue are those that were significantly different between responders and non-responders and were included in the responder predictor regression analyses. Here's some more measures and some more measures. The full TENS intervention protocol is published in the FAST trial. In brief, TENS was applied to the upper and lower back with butterfly electrodes using a modulated alternating frequency and the highest tolerable intensity. We encourage participants to wear the unit during exercise or activity. As mentioned above, the participants were classified into responder and non-responder groups. 2 sample t-tests or Wilcox and rank sum tests were used to identify candidate variables for the regression analyses. 2 responder predictor models were developed, one for pain and one for fatigue. NNT and NNH were computed from the absolute risk difference between the groups. From the selected variables in Table 1, those that differed between pain responders and non-responders was that initial response to the 30-minute TENS treatment, widespread pain index, and the fibromyalgia severity score. These were selected for inclusion in the pain responder predictor model. Likewise, the differing variables for fatigue responders and non-responders was that initial response to the TENS treatment, marital status, and sleep impairment. These were selected for inclusion in the fatigue predictor model. Here's a list of variables that were not different between responders and non-responders, and we did not go into the predictor models. For pain responders, a change in movement-evoked pain during the first 30-minute TENS treatment was the best predictor for pain response after 1 month of TENS. For fatigue responders, the response to that 30-minute initial treatment with TENS, along with less sleep impairment, higher MCS scores, and having a partner were predictors of those likely to experience that 20% reduction in fatigue after 1 month of TENS. Look at the great numbers for NNT and NNH for TENS. Between 3 and 5 is the number of patients one would need to treat in order to get an additional responder. 15 people in the active TENS group had some minor adverse events, and the NNH results suggest that between 20 and 100 people needed to be treated before one person would have one of these minor adverse events that could be well managed by the clinician. If you recall, NNT for FM medications was between 6 and 9, and the NNH was between 4 and 29. These data show that a pain reduction of just 10% was enough to identify those who might receive a 30% reduction in pain after the 1 month of TENS. For fatigue, it was basically any reduction following the first TENS treatment to correctly identify those who would experience at least a 20% fatigue reduction. To summarize, the change in movement-evoked pain and fatigue from the first 30-minute treatment with TENS predicts who will respond 1 month later. Rating pain and fatigue before and after a movement-evoked pain task is a simple assessment for clinicians to employ to determine who will benefit. When compared to medications used for fibromyalgia, NNT was lower and NNH was substantially higher for TENS, supporting the effectiveness and safety of this intervention. Our work that we presented today is currently in press in pain. It is an honor and a joy to work on this team, and I thank you for attending this poster presentation.